My name is Jennifer Hicks. I'm the Associate Director of our National Center for Simulation and Rehab Research, and I'll be serving as the moderator for the webinar today. I'm pleased to welcome today's presenters, Marjolein van der Kroot and Lynn Bar-Aan, who are joining us from the VU University of Amsterdam and KU Leuven in Belgium. They will be presenting on an individually tunable model of spasticity and contracture in patients with cerebral palsy. Can you bring up the next slide for me? So some quick background. OpenSim is a freely available software application for visualizing musculoskeletal structures and simulating how humans and animals move. The application has tools for inverse dynamics, optimization to estimate muscle and joint forces, methods to create simulations for motion capture data, and then tools to help you analyze and visualize the results of those simulations. So the first goal of our webinar series is to showcase research that's being performed with OpenSim. OpenSim is also a growing community of users. So the second goal of our webinar series is to provide a platform for the OpenSim community to communicate and collaborate. Next slide. So before we get started, just a few quick reminders about the format of the webinar. We'd love to answer your questions, but we'll address those at the end of the presentation using WebEx's Q&A panel. If you need any additional technical help, you can consult the guide that is on our website, and the link is right there. So after that, now I'd like to introduce our speakers. So next slide. So first, Marjolein van der Kroot. She earned her PhD at the Department of Rehabilitation Medicine at the VU University Medical Center. She then performed her first postdoctoral project, which was joint with the Tuneable lab here at Stanford University and Gillette Children's Hospital in Minneapolis. She then started a postdoc that was joint between the Biomechanical Engineering Group at the University of Twente and at the VU University Medical Center. And then since 2013, she's been a full-time research fellow at the VU University Medical Center. So Marjolein's research is aimed at better understanding walking pathologies in patients with neuromuscular and orthopedic disorders using musculoskeletal modeling combined with advanced gait analysis. Some of that today. Marjolein is joined by Lynn Bar-Aan, who is trained as a physiotherapist and also holds a doctoral degree from KU Leuven. Since October of 2014, she's been a postdoctoral researcher at the Clinical Motion Analysis Lab at the University Hospital Kellenberg in Belgium. Lynn's research is aimed at unraveling the pathological mechanisms that contribute to impaired motion in children with cerebral palsy with the aim to critically analyze and improve treatment outcomes. So Marjolein and Lynn are both very active in the OpenSim community, so we're really excited to have them as part of our webinar series today, really helping to bridge modeling and simulation to the clinic. Marjolein is also a past visiting scholar and a pilot project award winner from the NCSRR. So now I will pass the mic over to Marjolein and Lynn for their presentation. And I'm not hearing you guys if you have started.
Hello? Can you hear me now? Okay. Hello.
Yeah.
Well, thank you. Thank you very much for the introduction. We're very happy to have this opportunity to present our work. First, we'd like to acknowledge our funding sources, NCSRR, who awarded Marjolein with a visiting scholar grant, as well as a pilot project program, and the KU Leuven and FWO, who have funded my PhD and postdoc projects. Secondly, we'd like to thank our collaborators from Stanford, the Vrije Universiteit, and the University of Leuven. Here's an overview of what we'll be presenting today. So I'm Lynn, and I will first start with an introduction on cerebral palsy, followed by the goal of the study. Second, I'll explain the theoretical models behind spasticity and contracture, and introduce our research questions. Third, I'll describe how we collected the experimental data for this research using an instrumented spasticity assessment. Marjolein will then continue and explain how we modeled contracture and spasticity in OpenSim, and we'll show you some results. Finally, she'll discuss the implications of this research at what needs to be added in the future. Cerebral palsy has a prevalence rate of 2 to 3 per 1,000 live births. This makes it the most common neuromuscular disorder among children in Western countries. It originates from an insult in the developing brain. Children with CP develop abnormalities in movement and posture, which are caused by primary impairments as a direct result of the brain injury, such as weakness, balance, and problems with muscle tone regulation, including spasticity. These then develop into secondary impairments, such as bony deformities and muscle contractures, which worsen with growth and maturation. The severity of these impairments depends on the timing, location, and extent of brain injury. In addition, the clinical manifestation is patient-specific, as each child's development is unique. This results in a large variability among children with CP, with no two children having the exact same clinical symptoms. Neuromusculoskeletal modeling has been shown to be useful in trying to understand the complexity and variability of the impairments in CP and their effect on gait. However, most models rely on generic models, in which impairments such as spasticity and contracture are not regularly included. Therefore, the goal of our project was to develop and validate an individually tunable model of spasticity and contracture for the hamstring muscles in children with CP. The clinical symptom in children with spastic cerebral palsy is increased resistance to passive motion. This is caused both by alterations in the muscle's passive properties, for example, increased muscle stiffness and viscosity, and these contribute to contracture, and also by the primary neural factors that affect the muscle's tone, such as spasticity and increased background muscle activity. So what is contracture? Contracture is defined as an abnormal shortening of the muscle tissue, rendering the muscle highly resistant to stretch. How this shortening occurs is still a matter of debate. There's inconclusive evidence that the muscle fascicles are shorter in spastic muscles, but sarcomeres have consistently been found to be longer. In addition, there's some evidence that, at least in the contractured ankle plantar flexors, shorter muscles are sometimes compensated for with increased Achilles tendon length and compliance. A recent study by Smith et al. Has shown that specifically in the medial hamstrings, increased muscle stiffness is caused by increased collagen content in the muscle's extracellular matrix. Therefore, to model contracture of the hamstrings, we focused on altering the muscle fiber stiffness. What about spasticity? Well, the most common definition for spasticity is that of Lanz, who described it as a velocity-dependent increase in the tonic stretch reflex with exaggerated tendon jerks resulting from hyperexcitability of the stretch reflex. Simply described, the stretch reflex is activated when a muscle is quickly stretched and distension of the muscle spindles results in impulses being sent to the spinal cord via afferent pathways. Short and long reflex loops in the spinal cord are activated, resulting in efferent impulses returning to the muscle and causing a contraction. Depending on the movement being carried out, these reflex loops are modulated by supraspinal pathways that stimulate or inhibit them. In CP, modulation of the brain is disturbed, resulting in lack of inhibition of the stretch reflex and its consequent hyperexcitability. When assessing spasticity, this lack of modulation is experienced as a spastic catch, which interrupts the passive motion. So revisiting our goal of developing an individually tunable model for spasticity and contracture in CP, we asked ourselves, to what extent can these two phenomena in the medial hamstrings be explained by simple models? In other words, to what extent can we explain contracture by altering muscle fiber stiffness? And to what extent can we explain spasticity based on its definition as an increase in a velocity-dependent stretch reflex? To develop and validate our models, 11 subjects with spastic cerebral palsy with an average age of 11, and 9 age-matched typically developing children were recruited. Children who had undergone surgery or Botox 6 months prior to testing were excluded. The leg with the more affected hamstring muscles in children with CP and the left leg in typically developing children was tested with an instrumented spasticity assessment, or for short, ISA. ISA basically replicates a clinical spasticity test while simultaneously recording biomechanical and electrophysiological signals using simple instrumentation. 2 inertial measurement units, each containing an accelerometer and a gyroscope, to derive the knee angle. A 6 degrees of freedom force torque dynamometer attached to an orthotic to measure the forces applied to the tibia. And surface electromyography to measure muscle activation in the medial hamstrings and the rectus femoris. As in a clinical examination of the hamstrings, the knee was moved from full knee flexion to full knee extension. Here you can see an example of the movement carried out on a healthy adult. We carried out a slow movement and a fast movement to elicit a stretch reflex. The slow movement was at about 20 degrees per second, and a fast stretch was at an average velocity of 300 degrees per second. Here you can see an example of the slow and fast movements in a child with cerebral palsy. Unlike in these videos, however, the pelvis of the subject was additionally fixated to prevent additional knee motion coming from the pelvis. We will now switch microphones and continue the presentation with Marjolein, who will take you through the modeling of this experimental data.
Thank you, Lynn. So we wanted to create simulations of these instrumented spasticity assessments to see if we could create valid models for both contracture and spasticity. And we started with the generic OpenSim model, the Gauge 2392 model, and we scaled it down to individual subject size using height, leg length, and tibia length. We then fixed all the joints except for the knee, which was moved during the ISA test. And finally, we simplified the model by lumping the muscles over the knee into 5 main muscle groups, being the hamstrings, the vasti, the rectus femoris, the biceps femoris short head, and the gastric. And this was done because too little information was available from the ISA test to estimate the parameters for all muscles, for instance, for the 3 individual hamstrings heads separately. Our lumped muscles had the combined strength of the original muscles, but they followed the path of one of the original muscles and also had the total muscle tendon length of this original muscle. And the fiber to tendon length ratio was averaged over the original muscles. Finally, the force as applied to the tibia in the experiment was also applied to the model at the exact same position on the tibia as measured experimentally. We then loaded the measured ISA knee angles and applied forces into our ISA OpenSim model. And here you can see the measured motions of the slow in the top and the fast stretches imposed on the model in the bottom. And in a small blue arrow here, you can see the force as measured with the 6 degree of freedom dynamometer applied to the tibia segment. Now to get back to our first research question, which was, to what extent can we explain contracture by altered passive muscle stiffness? And in order to answer this question, we used the slow stretch data only, which was controlled to have only negligible muscle activity to make sure that we are really looking at the passive tissue stiffness. We calculated the net knee moment around the knee using a standard inverse dynamic approach, similar to inverse dynamics used during gait, using the measured motion and the forces applied to the tibia. And next, we optimized the passive muscle stiffness parameters in the model to fit this net knee moment, as I will explain in detail in the next slide. And we then evaluated how well we were able to explain our measured data. First, here you see the measured net knee moment as obtained from the inverse dynamic analysis, averaged over the TD children in blue and the children with CP in red. On the y-axis, you see the passive net moment around the knee, and then on the x-axis, the knee angle. And as expected, the children with CP in red were considerably stiffer, both towards knee flexion and towards knee extension. As explained in the introduction and based on available literature, we chose to model contracture by adjusting the passive stiffness of the muscle fibers. And here you see the general muscle active and passive force length curve as present in the standard Thielen muscle model in OpenSim. As we did not have any data on active force length curve in blue, we did not make any changes to this. We only adjusted the parameters describing the passive force length curve in black, and these are mentioned in the formula as F and K. F stands for the muscle strain at maximum isometric muscle force, or Fmax muscle strain. And this describes the amount of stretch of a muscle when a passive force is applied equal to the muscle's own optimum force. By default, this amount of stretch is 60% or 0.6. And a higher value of F thus means a less stiff muscle, as the muscle is stretched more for the same force. K stands for K-shaped passive and describes the shape of the curve, with a higher K indicating a more concave curve and lower K for more linear curve. The values of Fmax muscle strain and K-shaped passive can be easily adjusted for any muscle in your model by browsing to the muscle in the navigator window and scrolling down to the correct properties in the OpenSim GUI, as you can see here. However, we wanted to optimize these properties, and therefore we did not adjust them in the GUI, but rather we used MATLAB to load a model, then adjust the K and S properties, and then run an optimization. This is where you see the properties. So this is illustrated here in more detail. We started with our ESA model with 5 muscles with default values for the passive properties K and S. Input to the model were the measured knee angles and the applied forces on the tibia. We then ran a muscle analysis to calculate the passive forces for each muscle, and we summed those to obtain the model's net knee moment over the entire range of joint angles during the passive stretch. This is then compared to the measured knee moment as obtained from the inverse dynamic analysis. Next, the K and S for the hamstrings and fasciae were adjusted automatically using an optimization algorithm in MATLAB, the FMIN search algorithm for those interested. And the process was rerun until an optimal fit was found between the models and the measured knee moment. We optimized only the parameters for the hamstrings and fasciae, as we were most interested in the hamstrings. The fasciae was also needed as it is a large influence around the knee. The other muscles in the model, so the gastroc, the rectus, and the biceps femoris short head, were all far from their end range of motion during the entire test, and they had only very little influence. So it was not needed to adjust these parameters, and it was also impossible to estimate the properties reliably using the current data. Here you see again the measured moment angle curve in solid lines, and I will add now in dashed the optimized curve averaged overall subjects. And as you can see, the measured and the modeled moment angle curve almost perfectly overlap. And this means that the passive knee moment could be perfectly replicated by tuning only F and K, so only the passive fiber stiffness for the lumps, hamstrings, and fascia. And this is true not only for the averages, but for each individual subject, as you can see from the RMS errors, which were really small and in the order of 1 to 2%. Especially for the children with CP who had a steeper curve, we were able to fit the curve really well by tuning only the fiber stiffness parameters. Here you see again the passive force length curve of the standard Thielen muscle in the thick black line. Now if we add the resulting passive force length curve based on the average F and K values for the hamstrings, for TD in blue and CP in red, you can see that the CP hamstrings almost exactly resembled the default model, while the TD hamstrings in these children were considerably less stiff. And the main significant difference was a higher S value for Fmax muscle strain in TD, or a lower value in CP. And thus, for the same optimal force of 1, TD muscles were stretched more to 82% versus 57% for the CP muscles. You can also see from the numbers that there are quite large standard deviations, so large differences between subjects. And this means that the stiffness differs considerably between subjects, but also that our optimization method was able to individually tune these S and K values to match the measured passive moments. If we now add the fasti muscles, you can see that these were way less stiff than the default model. The curves are really at the bottom for both the CP and the TD children. And so those didn't fit the generic passive force length curve at all. Finally, to give an indication how the tuning of these passive muscle stiffness parameters can affect the simulation, we performed a predictive simulation or forward dynamic simulation of the slow stretch data. And as input to this predictive simulation, we used models with first the default and then the optimal passive properties. We set the model in the initial position as measured experimentally, and then we imposed the measured forces to the tibia. But the movement was totally free, and the output of these simulations was then the resulting knee motion of the knee, which was compared with the experimentally measured knee motion. So if we did a good estimation of the model's properties, these two motions should match. First, you see here the predicted motion by the forward dynamic simulation if we didn't tune the passive muscle stiffness in top. And as you can see, the knee directly goes to extension very fast. And this is due to the high stiffness of the fasti muscles, which did not at all match the passive neck knee moment. And especially in a simulation where forces are low, as in these passive tests, you can see that this has a large influence. However, if we tuned the hamstrings and fasti passive muscle stiffness, as you see in the bottom video, we get a very close fit for the motion. In red in the background, you see now the measured motion for a reference, and in white in front, the simulated motion, although it's kind of hard to see the difference as they really lie behind each other. The fit was again best for the CP subjects compared to the TD, as they had stiffer muscles, and we got as close as about 1 degree of RMS error between the measured and simulated motions. So to conclude about simulation of contracture, we can say that passive muscle stiffness could fully explain the muscle behavior during the slow passive stretch. It could also be individually estimated based on slow stretch ESA data, and we can say that muscle stiffness is higher in CP as expected and variable between subjects. Now what about spasticity? To recall our second question, we wanted to know to what extent we can explain spasticity by a purely velocity-dependent stretch reflex. And as we wanted to truly predict the effect of such stretch reflexes, we performed again forward dynamic simulations, now of the fast stretches, and again I will explain in more detail in the upcoming slide. For the fast stretches of CP, we included stretch reflexes, and we evaluated the model outcome in terms of predicted knee angles, muscle activity, and fiber length and velocity. And here you see this outlined in a bit more detail. As input to the forward dynamic simulations, we used the ESA model with the passive muscle stiffness parameters, so S and K, tuned for each individual subject based on the slow stretch data. We set the model again in the initial position as measured experimentally, and we then imposed the measured forces again to the tibia. The output of these forward dynamic simulations were then again the resulting motion of the knee and the muscle activity, which was 0 as long as no stretch reflex was present, as it was fully passive. But for the fast stretches of the CP subjects, we added a spastic controller to the hamstrings, which would activate the muscle depending on the stretch velocity, and this resulted then in non-zero muscle activity. The predicted knee angle and hamstring activity were then compared to measured knee angle and EMG for validation. The hamstring's fiber length and velocity were also evaluated to gain a more in-depth insight in the controller's behavior. First, you see here the modeled motion for an example CP patient if no spasticity was included. In red in the background, you see again the measured motion, and the white model shows this simulated motion. And as you see, there is a large overshoot of the knee angle, resulting finally in a sinusoidal motion. This same knee angle over time is shown in these graphs, averaged over all TD subjects on top and for all individuals with CP on the bottom. And the black line is the measured knee angle over time, as you can see here, which moves from flexion towards extension. The green line represents the predicted knee angle. And for the typically developing children, you see that on average the predicted knee angle matches well with the measured knee angle. For CP, however, you see that there is a clear overshoot of about 30 degrees. And this overshoot can be explained, of course, by the fact that in reality there is spasticity in these patients, which causes the muscles to become active and resist this motion. And therefore we needed to include spasticity in our model. As explained earlier, we wanted to see whether a relatively simple model of purely velocity-dependent spasticity could explain the experimental behavior. And therefore, we implemented a controller using the OpenSim API, which would give an excitation to a muscle anytime this muscle would be stretched above a certain threshold velocity. The amount of activation could be scaled by a gain factor, which basically represents the severity of the spasticity. And furthermore, a time delay was introduced, representing the stretch reflex delay. So in total, our model contained 3 parameters, threshold, gain, and delay, which could be individually varied. For our data, we chose to fix the delay to 30 milliseconds, representing the shortest possible stretch reflex delay as obtained from literature. The threshold was set to a value directly based on the measured data, as the muscle tendon lengthening velocity 30 milliseconds before a clear onset was seen in EMG activity. And for the gain, we chose 4 different values ranging from 0 to 4. And we used these for all subjects to cover the range of possible realistic values. And this was based on pilot testing. This spastic controller could then be added to any OpenSim model at the bottom of the .osim model file, as you may be familiar with. As you can see here, in the bottom you see a controller added, which has in which you choose the muscle on which it acts and the values for the 3 parameters, threshold, gain, and delay. This was modeled as an OpenSim plugin, which need to be copied to the OpenSim installation folder and then can be loaded through the tools menu as a user plugin, as you can see here. And once that is done, and a model with spastic controller included is loaded, then the controller parameters can be seen and adjusted in the property window, as you can see here. And so for our subjects, we implemented a model for each subject with CP with the spastic controller individualized threshold values. And here you see on top again the simulation without spasticity, as we saw earlier. And in the bottom you see a simulation with spasticity included. And as you can see, the fit improves a lot. Only towards the end range of motion, a small deviation is still seen. Now let's see how this improves the fit of the knee angles averaged over all subjects. Without spasticity, there was a clear overshoot of about 30 degrees. With increasing levels of spasticity, you see that the knee angle decreases. And with gains of 2 and 4, a clear break in the movement is also seen. What you also see is that with an average gain of 2, the first part of the motion is predicted best, so this is in purple, and a gain of 4 in red gives an undershoot and too much of a catch motion. Towards the end, here, all simulations continue to overestimate the knee extension angle with 15 to 20 degrees. So we see that there's a clear improvement with including spasticity, especially in the first part of the motion, where we still get a small overshoot at the end. And this offset at the end range of motion can be explained if we look at the muscle activity predicted by the model compared with measured EMG. Here you see a typical example of measured EMG in blue and predicted muscle activity in red. And both are scaled to their maximum value during isometric contraction. We found for all subjects a really good match between the measured and simulated activity during the main part of the stretch phase. Only at the end of the measurements, we see that the measured EMG remains on at, in this case, 5 to 10% of the maximum, while the simulated activity stops. And this is because the simulated activity is dependent on stretch velocity, as we modeled it, and the muscle is no longer lengthening, and so the velocity is not above the threshold velocity. This phenomena of prolonged activity that we see in patients is often seen in these patients with CP, and also during these ESA measurements, but it could not be explained by our simple model. Now, to tune the gain value for each individual subject, so basically to see how strong the spasticity of each individual subject is, we looked at the difference in predicted with measured knee angles. We quantified this by the RMS difference in degrees for all subjects and for all gain values, as you see listed in this table. And here we focused on the stretch phase only, so not putting too much emphasis on the offset in prolonged activity. And these are a lot of numbers, of course, to look at. But if we look at the boxes in green, these indicate for each subject the lowest RMS value, so the gain value with the best fit on the data. And as you see, most subjects had a best fit with a gain of 2 or 4, while 2 had a lower score of 1, and 1 even had a best fit with a gain of 0, so without modeling any spasticity. So this shows that we were able to tune the gain value for each subject to get a best fit. On average, the prediction of the knee angle was about 6 degrees off for the most optimal gain value, as you see in the bottom. And this is equal to the value for the healthy subjects, or TD children, without the addition of spasticity. So with including spasticity, our fit improved to be as good as the fit for the typically developing children. Now, if we zoom in on the one CP subject, number 5, with an optimal gain of 0, indeed we saw that this child had only very mild spasticity, with a clinical spasticity score, the modified Ashworth score of 1, which is a very low score, where all others had a 1+ or a 2, meaning that there was a clear catch. In the knee angle curve for this particular subject, indeed you see that the measured data in black is best matched by the green line representing a simulation without spasticity. On the right here you see another example with a higher level of spasticity and an optimum gain of 4. In this case, you see that the green line without spasticity is far off, and you see that the red curve best matches the measured data in black, especially in the beginning, but also that there is a much larger overshoot towards the end. Now we are getting towards the end of this webinar. Finally, we looked at the underlying behavior of the spastic muscles in terms of their fiber length and lengthening velocity. And in these graphs, you see the fiber length on top, then the fiber velocity, and the fiber activity over time for a typical example. Without spasticity, as you see here in green, both fiber length and velocity move smoothly, and there is no activity seen. With increasing levels of spasticity, we see a more spiky pattern with a clear break in the length and lengthening velocity, resembling a catch, as also felt experimentally. And also in the activity, we see an increasingly spiky pattern at the higher levels of spasticity. And this seems to us to resemble a clonus reaction, as sometimes seen in spastic muscles, although mostly in the calf muscles. So in conclusion, we have already seen that passive muscle stiffness seems to be a good method to model contracture for the hamstrings in TB. We can now also say that our purely velocity-dependent spasticity model seems to predict the behavior of the muscles quite well, as we could quantitatively predict the measured motion, the increased muscle activity, and we also qualitatively observed something that seemed like a catch in the fiber length and velocity, and even a clonus. We showed that the parameters of the model could be tuned to individual patients with a range of severity in their spasticity. However, prolonged muscle activity after the stretch phase has ended could not be predicted by just a velocity-dependent model. Of course, there are several issues in this study that need some further consideration. First, although we explicitly wanted to investigate how well we could explain our data with relatively simple models, obviously we are also missing several aspects of pathology that could be relevant depending on the application of the model. And specifically, we could not personalize any of the active muscle properties, nor did we adjust tendon properties. And more sophisticated data collection protocols are needed to assemble enough information to be able to include these properties in the model. Furthermore, several studies have shown that not only velocity-dependent feedback is enhanced in TP, but also length and force-dependent feedback. And some of the prolonged activity may be due to this length and force-dependent activity. But it could also be due to other neurological effects, such as persistent inward currents. We also found that passive muscle stiffness was quite different from the generic muscle, especially in the vasti, but also in the hamstrings of the typically developing children. And this may be due to some extent to the fact that the passive force length curve is scaled to optimum force, which is obviously quite high in the vasti. And these forces had a considerable effect, especially in simulations like these, where overall forces are low compared to, for instance, walking. It is thus important to be aware of this and to individually tune these properties where possible. Finally, our controller worked well, but also made the simulations quite a bit slower. So that is something to improve upon in order to do larger simulations with more muscles, for instance, during gait. In the near future, we plan to further validate our model using ultrasound during the ESA tests, which Lynn is now working on, to quantify muscle and tendon length changes, and also to validate our outcomes with more data. We also plan to extend our analyses to more muscles and to apply individualized models, including contracture and spasticity, to gait simulations to see whether this improves the model outcomes and to investigate to what extent we can or cannot simulate normal walking when we include contracture and spasticity, and to see where these phenomena most limit our normal gait. To end this presentation, we hope that you can all contribute to our challenge of explaining the effects of contracture and spasticity in individuals with TP and other patient populations. And therefore, we plan to make our spasticity plugin and the source code available on our project webpage on SimTK as soon as our paper comes out in the coming months, so that you are all free to use and further develop this. If you're interested in testing it earlier than that, feel free to contact us and we can share the code. I would like to end with acknowledging once more our funding sources and co-workers, and I would like to thank you for your attention. And now Lynn and I are happy to take any questions that you may have.
Thanks, Marilyn and Lynn, for a really great talk that was super clear and a really interesting combination of rehab and simulation. So thanks again. Now we can get started with the Q&A session. So as I said at the beginning, all the questions will be text-based. So find the Q&A box on your WebEx controls, type in your question, and make sure you select to ask all panelists. So while people are figuring out how to use the WebEx controls, I'll go ahead and ask a question. I was really interested in your final slide where you were talking about some of the next steps, and I was wondering how easily this framework would apply to looking at modeling spasticity in other muscles, and how variable you think the gains might be for different muscles in one subject.
Thank you, Jen, for the good question. It is really easy to apply the model to different muscles because you can just load the plugin, and then in your model file you can indicate which muscle you want the model to work on. To say whether the gains are going to be different in different models, that is really hard to say. I think they would be in the same order of magnitude, but it can very well be that for different models, yeah, you find different values. And that is something we are planning to look at, especially for the calf muscles, the gastroc and the soleus, to see if we get comparable outcomes.
And do you already have the ESA experiments for the other muscles?
We do have ESA experiments for the gastroc and the rectus. Maybe Lynn can comment on that.
Yeah, we have ESA experiments for the gastrocnemius, for the rectus femurs, and for the adductors.
Okay, great. So now we have some questions coming in from the audience. So Kat Steele, I think, is watching with a group of people at the University of Washington, and they have a couple questions. First, they said it was a very clear presentation. And the first question is, did the spasticity for dynamic simulations include the altered passive properties from the slow contracture simulation?
Yeah, so during the simulation of the fast stretches, we used the stiffness properties as obtained during the slow stretches. And this was really needed to get even close to the measured motion. So we really had to adjust those first using the slow stretch data, just the stiffness properties, and only then we could apply realistically our velocity-dependent spasticity model.
Okay, thanks. And then their next question is a good one, and you talked about it a little bit already, but can you elaborate a bit more about why you think the passive properties for the vasti were so different?
Yeah, that's something that really surprised us as well. Although we knew that the passive stiffness of the vasti is rather high in the vasti. We have seen that also in gait simulations, where the forces in the vasti are pretty high during gait as well, especially in the swing phase where the knee is flexed. You see that the vasti muscles deliver quite some passive force, which seems to be an overestimation of what would happen in reality. And we've seen in an earlier study that if you weaken these muscles, the passive forces go down a lot as the passive force scales with the strength of the muscle, then it becomes a lot more realistic. And so therefore, I think the main reason that it's so far off for the vasti is that these passive forces scale with optimum force, and that this assumption is a general assumption for any hill-type muscle. It may just not be a realistic assumption, and it might be better to determine the passive properties more independently from the active properties of the muscles.
Yeah, so when Sam Hamner, who's a grad student here at Stanford, when he was simulating running, he found that he shifted the passive curve for the vasti as well. So it's a known issue.
Yeah, but that it would be so much off, and that those passive forces would be high enough that if you just place the subject with a bent knee lying down, or the model with a bent knee laying on the back basically, that it's the passive forces are really high enough to just make the leg move up quickly. So that seems really unrealistic.
Yeah. All right. So now I have a question this is from Nathan Smith, and he says, thanks for the great talk. Is it possible that the prolonged hamstring activity during the later phase of the slow stretch could be better captured by altering the velocity threshold of the controller?
I don't know if I understand correctly, but so what we saw was the prolonged activity during the fast stretches. And so the question is whether this could be explained perhaps by using a different threshold. I don't think that would make a difference. It does, of course, affect the simulation. But in this second phase, there really isn't any motion anymore in the joint, so there isn't a stretch of the muscle anymore. So therefore, if you just have a velocity-dependent activity, no matter what the threshold velocity is, this model would never predict activity in this phase. So we would really have to include either a length dependency or some other more complex neurological effects to explain this.
Okay. That makes sense. Now a question from Ying Fang. He or she says, thank you for the great presentation, and was curious, so this is a methods question. So how do you determine the force that's applied to the shank, so the blue arrow that you showed in that model pictures, and how did you add that force to the OpenSim model?
So the first part of the question, how did we determine it, is based on the experimental data. So in the experiment, we used a 6-degree of freedom force dynamometer that measures the forces and the moments that you apply to the tibia. And these measured forces and moments we then applied also to the model. So we measured also the distance to the knee joint axis in different directions to see where exactly we applied this force. And then we imposed it just in the exact same location also to the model.
Okay, thanks.
I hope that answers the question.
Yeah, I guess if there's still questions, go ahead and type any follow-up questions you might have. So now going back to the Steele lab at the University of Washington, they also wondered how much did the spastic threshold vary between participants?
Not very much, no. They were all in the order of 0.05 to 0.1 meters per second, so really low actually. So really at the beginning of the motion already the activity was evoked. Lynn wants to...
But if I can just add, what we've also found is that there's more variability between different muscles, so that the hamstring and adductor muscles seem to have a lower threshold velocity than the gastrocnemius and the rectus femoris. So I think there's larger variability between different muscles rather than between different subjects.
Yeah, so we found that the gain factor, so really the strength, the scaling factor of the spasticity had much more of an influence and differed much more between subjects rather than the threshold value.
Okay. So now a question from Julian Arnaud. Sorry if I mispronounced that name. So the question is, I'm going to try to interpret this one and hopefully I get it right. So for the ESA testing, have you considered doing that testing by applying the torque with a motor-driven device like a Biodex or something like that?
So yes, we have considered that, and it was actually done for the calf muscles here in Amsterdam. And we've recently also made a comparison between a motor-driven spasticity test and our manual spasticity test. And we found that the way that the displacement is applied really affects the kind of stretch reflexes and the kind of activation that you get out of the test. So our theory is that the stretch reflexes actually respond more to a change in acceleration rather than to a certain velocity threshold. Because what the motor-driven system, most motor-driven systems do is they apply a very high acceleration to reach a constant velocity, whereas our velocity profiles were more bell-shaped. And so our theory is that this evokes different kinds of stretch reflexes depending on the equipment you use to evoke a stretch reflex. You can control better the torque applied, but since that's an outcome parameter, you can either control, with a motor-driven device, you can either control the velocity or the torque applied, and most motor-driven systems control the velocity applied.
Mm-hmm. Okay, thank you. We have time for one or two more questions. Now a question from Zajad Zajarian. So this is a beginner to OpenSim and is wondering if you guys have tried to model muscle co-contraction, and if so, or if you have ideas on how you might do that.
Well, in this study, obviously we have not, and we have actually seen that we've sort of controlled for it. We've made sure that we had EMG on both the agonist and antagonist. We've controlled that there wasn't a lot of muscle activity in the antagonist to make sure that that wouldn't affect the motion.
And I think co-contraction should best be modeled during activity because that's when it's most present. So during gait, I think that there are some models of co-activation or co-contraction, but we haven't done that yet.
Okay. So if anybody else has a final question, go ahead and get that in. I guess I'll ask the question. So it would be really exciting to apply this to simulations of gait. How much do you think including spasticity might change predicted muscle activity compared to EMG or other aspects of the simulation?
Well, I think it can affect the simulations quite a bit. Actually, this relates a little bit to the previous question, because what the spasticity does during gait is it makes the muscles active in phases where they shouldn't be active, and can have a counteracting effect. So I would expect that it actually results in more co-contraction, because the negative effect of the spasticity needs to be counteracted by muscles at the opposite side of the leg to make sure that the desired motion is still generated. So in this case, I could imagine that there is too much hamstring activity, for instance, in terminal swing due to the spasticity. And if you would still try to simulate normal gait, you would have to counteract it by making your vasti also active. And that could result to increased co-contraction.
And I think that equally important, the models of contracture will help us to simulate the gait data better.
Okay, thanks. I guess we'll have one final question, and this is from Michael Orendorf. How do you suggest handling the variance of spasticity that's generated or demonstrated by children with CP over different days or times of days?
That's a difficult question for the end. We already saw that between the different trials within one test session, there could be quite a difference, and we chose individual stretches basically to model. So yeah, I think that spasticity can vary quite a bit over days.
Yeah, despite the fact that we also did some reliability studies with the instrument spasticity assessment, and when you have variability in your data, but you average it. So by repeating the test several times, we seem to get good reliability data. So that the quantitative parameters that we got out of the tests were not very variable between those.
Okay, that's good to know. All right, so I think we'll go ahead and wrap up. Thank you, everyone, for a really great discussion. Thanks for all the great questions. Can you go ahead and move me to the next slide? All right, so we already did questions, so thanks everyone for all the great questions. So OpenSim and this webinar series are supported by several grants from the NIH, including an NIH grant that funds our National Center for Simulation and Rehabilitation Research. We're also supported by the DARPA Warrior Web effort. Next slide. So thank you again for joining us and asking questions. Information about the center, upcoming events, and other resources for the OpenSim community are available on our website. We'll also follow up with an email that will have a link to a recording in case you missed anything from the presentation, and it will also have a link to Lynn and Maryline's SimTK project if you want to learn more about what they're doing. And we also ask that you please complete the survey that will appear in the pop-up window at the conclusion of the webinar. So thank you again, everyone, for participating. Thank you, Maryline and Lynn, for a great talk, and we hope everyone will continue to stay involved with the OpenSim community.